Afternoon, everybody. So we are going to talk about the controversies in management of MS. But I've basically made this talk a little different. I made it not the controversies, but the dialogues in MS, so that we don't have people who are already stalwarts in the field of MS fighting with each other. And so I made it a dialogue in MS. So I would just put you across to a certain situation that we see in day-to-day clinical practice and how to deal with it. And we have three very, very eminent people in the field of MS. Of course, we have Dr. Rohit Bhatia from All India Institute of Medical Sciences, Dr. Dheeraj Khurana from PGH Chandigarh, and my dear friend Dr. Suresh from Kochi. So I think with their vast experience in the field of MS, they would throw some light and make our working day-to-day working of MS much easier. So I have certain cases which I'm going to put forward, and then I ask all of them to throw some light on this. So we had a patient. This is all of these cases are real cases. They are not. They are all. So I had this 25-year-old female. She had this first episode of optic neuritis, and she received IV methylprednisolone. She did very well. She recovered completely. Her MRI in brain and spine and showed no other demyelinating lesion other than the enhancement in the optic nerve, which is right optic nerve. We went ahead and did a CSF. The CSF was positive for oligochondral bands. So now the first question that arises is what to do now? Should we treat us as MS, and what should we do now? So I think first I will ask Dr. Suresh, how would you approach this case?
Thank you, Dr. Anshu and Dr. Arun Garg and my co-chairs here, panelists. See here, actually, it's a unilateral optic neuritis.
This is a unilateral optic neuritis.
Unilateral optic neuritis. So, and this patient doesn't have any lesions in the brain, and a CS of OCB is positive. So clinically, if you look, this fits into a clinically isolated syndrome with negative MRI, and maybe CSF OCB positivity shows that there is some dissemination in time in this person, because there is OCB is, according to 2017 McDonald's criteria, OCB can be taken as a dissemination in time. So we have one optic neuritis and we have one CS of OCB positivity showing that there is dissemination time, but dissemination space we do not have. We have an isolated optic neuritis without any. So probably in this patient, in the acute optic neuritis attack, I would treat him with IV methylprednisolone and followed by oral steroids and see for the vision to improve. If it's not improving, then the other options can be tried, like IVIG. But most of them do respond to methylprednisolone, and the vision improves to near normal. I wouldn't label this patient multiple sclerosis right now. That is the important message which I would give right now. Probably I'll keep this patient under watch. It just could be an isolated optic neuritis, but CSF OCB positivity has to be given some importance. And I will wait to see if this patient later on goes on to develop new lesions in the brain or develops another attack, and can I more confidently make this patient a diagnosis of multiple sclerosis. So right now I won't decide to start on any disease modifying therapy in this patient.
Dr. Rohit, what would be thoughts on that?
Thank you, Dr. Anshu. So I think this is although this is a unique situation, but it is not extremely uncommon. So we do get people who have no radiological finding, but OCB positive. Now, if you go by a very strict consensus on the criteria do not lay down such situation in the McDonald's criteria. What would you do and call a person who has optic neuritis but no radiology but OCB positivity? What we more get is radiology, and we want to look for OCB positivity in the first instance. So the second thing that I would, of course, would want to know and would want to do more, because oligoclonal band positivity is not unheard of in other optic neuritis as well. So it's to know if they are serologically positive or not. Let's say this person is strongly serologically positive for MOGAD or for
Uh,
NMOSD, then you can move in that
yeah, no,
direction.
we are considering that she is MOGAD and NMO
Yeah,
negative.
so that is an information that needs to be transcribed to know that you're not dealing with a optic neuritis which just has oligoclonal band positivity as an intrathecal synthesis. If you rule that out also and you strongly feel it's a recovered optic neuritis post steroid, the age is fitting into a monoocular disease, then this would be categorized more as a clinically isolated syndrome by the old criteria. Now, it is important for us to discuss with the patient the data which is even there for CIS, what has been published. Even though if you go back into the CIS radiology, a large majority of the patients did have radiological imaging in that era, which would have been in post 2017 categorized as RRMS. So not that too many people had zero radiology. But if you go by the ONTT trial, we know that as the number of lesions are more, the risk of having MS, clinical MS increases. So I think I would definitely give the patient a fair understanding about what the science says about CIS, the rate of conversion if you are on a DMT versus not, the risk and benefit of wait and watch versus the risk of having another event. And if the patient is willfully understanding of the fact that he or she prefers to be on a treatment that could stop her disease to manifest further or enhance her chances of lessening the risk of having MS in the early phase, I'm talking about the first 2 or 3 years, it may be worthwhile giving that option to the patient.
Dr. Dheeraj?
I think most of the facts have been elaborated. A couple of things which I would really be interested in knowing, just in purview of the limited information that you have given us. OCB positivity, apart from that, certain clinical features would be very relevant
Yeah.
in understanding. Was there a painful?
It was a painful optic
Right,
neuritis.
so
It was a
that
painful
goes
optic.
in favor of MS. That's one more thing. Number two, I would be interested in knowing the recovery pattern. How
Yes.
good was the recovery?
Yeah,
You
the
gave
recovery was good. She recovered very well with the.
excellent. So these two things again, of course, we're still thinking it's MS, but these go highly in favor of a MS kind of optic neuritis. And like Rohit did mention that CIS, we had earlier studies with interferons, which clearly showed if you treated CIS, there was a greater chance of these people delaying the onset of going into CDMS by whatever criteria was being used in those times. So I would do a similar thing, tell the patient if this is, and also I would get an orbit MRI to see the pattern of involvement just to be sure, are we okay with the MS phenotype? Is the optic nerve involvement just like MS, what we see? And then take a final call on it and telling the patient the choices. Either we leave the patient off the treatment, wait for a second episode or a second MRI. So it may happen that you repeat an MRI after 3 to 6 months, you get a single lesion, everything's done, you have more than one or two lesions, and you can possibly start the treatment. OCB positivity, I actually would expect some lesions to be actually there. It's rare that you get an OCB and an MR. It's a very disconnected kind of a thing. MR which is negative. So, and in the spine you said was normal.
Yeah, spine was also normal.
So I would also have a shared decision making kind of a scenario and and tell the patient about all the facts in terms of the risk of attaining MS or getting into MS versus still staying as isolated optic neuritis off the treatment.
So I think I would conclude with that you have to basically discuss the option with the patient that the patient is may likely to go on to develop MS. And I think after the discussion, you can take a call. I think both the approaches are equally good. You can wait and watch, or you can give the patient the option of starting a treatment, telling that about the ONTT trial that the patient may likely to go on and develop MS over the next 5 to 10 years. I think we can go to the next case. So now this was a 24-year-old female lawyer, works for the for the Supreme Court. She was initially based in Mumbai, and she had a history of migraine. She was seen by a neurologist in Mumbai, and she undergoes a MRI brain, spine, optic nerve, and all that. And the MRI brain reveals multiple white matter lesions, and the contrast steady and the MR spine were non-contributive. There were multiple white matter lesion, very, very classical of MS. The evoked potentials were normal, the vasculitis workup was normal, and the CSF is positive for oligochondral bands. So now what to do? Dr. Suresh? Because I have this patient, she is right now with me. So I would like your opinion, and she is already on treatment for the last 2 years. So she just moved from Mumbai to Delhi. So I just wanted to have all these three stalwarts telling how to go about it. And she is a lawyer. Be careful.
So it's again a very tricky situation, and okay, if in her migraine is the only symptom.
Yeah, migraine is
The
only.
only
She is totally
symptom. There's
asymptomatic.
no other symptom
Absolutely asymptomatic.
to any neuroaxis involvement. There is no symptom suggesting that. So one thing is that, so it's only a migraine, and there are no signs on examination also.
Absolutely
She
no
doesn't have
sign.
any
She has
pyramidal or
no
nothing in there.
signs, and all her
Okay.
imaging is absolutely.
So we are just looking at a patient's MRI who has a history of migraine, and then we are seeing some white matter lesions in this patient in the MRI, and the VEP etc. all are negative, and then finally we have again a CS of OCB which is positive. Okay, so in this patient, I would be very interested in the MRI of the patient. Actually, we know that there can be non-specific white matter changes in the MRI in patients. So I would like to see where are these white matter lesions. Do they confine to the McDonald's criteria? Are the typical sites of MRI
Yeah.
involved, like the juxtacortical and brain stem? So we have four typical sites where after 2 out of 4 can give us a diagnosis of MS. So in migraine, they do not follow that pattern. It's more like a subcortical white matter, bilaterally scattered kind of a white matter lesions, what we used to previously call as unidentified white matter. So in this patient, CS of OCB is also
Positive.
positive. So
And she's already been put on treatment by one of my colleagues. So I'm just asking, what should I
yeah,
do?
I wanted to ask the question about the MRI. Are they in very typical
MR,
site? And
MR
are they
findings, MR is very typical of MS.
typical of MS? So, okay, we have a radiology which is quite typical of MS. We don't have any symptoms or signs suggestive of a neuroaxis involvement. And there is a CS of OCB which is positive. 90% of patients with MS have CS of OCB positive.
Lawyer, Supreme Court lawyer. So be careful.
Yeah,
So
but I don't think so.
I
That
wanted
will-
to add
that
more
will-
spice. No?
That will really change my approach to her because she's a lawyer. I don't know, I wouldn't do that. But I would be very again to start her on treatment for MS, like without any clinical symptom or sign. Should I just start a patient on radiological and CS of OCB positivity? Yes, sir. So I think again I would like to wait
Very
for a
much.
neuroaxis symptom to appear before starting.
Okay, Rohit, your comments.
So, if I see a young person of migraine with radiology, which is white matter disease, there are a few differential diagnoses that we must exclude, including CADASIL and CADASIL. So, that is, as a neurologist, going in your mind in parallel. And that is good for the residents here to understand that migraine as an accompaniment of white matter disease can be in many conditions. So, keep yourself alert, take a good family history, and ensure yourself that you're not dealing with a vasculopathy and that you say this is an isolated radiological syndrome. So, coming to the discussion point, and I think that's where we're coming from right now, is that you're dealing with a young female who gets an MRI incidentally because of a migraine. And if you see a white matter disease in there and you've kind of thought and you've said, okay, the lesions are very classic of MS, so this is looking like a radiologically isolated syndrome. The one big controversy which exists even in 2024 is to understand radiologically isolated syndrome. And the two facets of that is can we predict patients who are more likely to develop MS? And are we there yet to say that you are a patient who should be treated, because we may be looking at the initial prelude phase of a disease before it has broken down to a clinically isolated syndrome? Now, few risk factors which have been quoted and repeatedly quoted are male, gender, people with spine imaging abnormalities at baseline, people with contrast enhancing lesions at baseline, and people with oligoclonal bands positivity. These are those patients where a risk estimate of conversion in the next 3 or 5 years is up to even 30% to develop MS attack before you will say this is MS. However, said that, we also have patients of RIS whom we have been following. And the beauty of RIS is that if you repeat their radiology, they will keep on having new lesions. They even will have contrast enhancing lesions on follow up, but they will still not be symptomatic. So, till 2024, we did not have any evidence. No, I mean, saying evidence here means of treatment, because people would be given this judgment and this explanation, and then we would somehow tend to leave it to a patient to decide whether he accepts the risk of watching, or he says, no, no, मेरे को इलाज करना है, आप कर दो. I want to be treated as MS. But honestly speaking, other than the recent trial that came for teriflunomide in JAMA for RIS, we did not have any evidence to support its use. Even as of now, even after that previous study which has been recently published, and the editorial which came for one of the papers in Lancet, we still do not have a clarity that RIS should be treated. Honestly speaking, if I see a patient who has enormously enhancing lesions or a cord lesion, I would probably discuss with a 50% equipoise whether I should treat or not. But if I see scattered radiology is looking like MS, patient is doing well, we clearly know that this patient has got migraine, I would probably not end up treating. I would explain them, I would follow that patient up, and just not be in a hurry to start a disease modifying treatment. As of now, there is no consensus, and it's a debatable topic whether you want to treat RIS or not.
Dheeraj?
Well, of course, this is quite debatable and has pros and cons on either side. So, like Rohit just elaborated, there have been some, if we have an RIS and we have certain other risk factors associated with it, the chances of it converting to MS are high. So, he's elaborated them. This patient only had one, at least OCB positivity, and I don't know if you've specified the number of bands
Bands
and the
are-
IgG index. I would actually look at the
Both
IgG
of them
index.
are positive. The IgG
So,
index and
so
the
the
bands
index
are
is high. That actually entails a higher risk. Of course, lesions, contrast enhancing, and if it is there in the cervical MRI too, a lesion in the cervical MRI, that carries a still higher risk. Lawyer or no lawyer, I wouldn't give. I would blind myself to that and keep a neutrality in terms of that, because we need to be following evidence, of course, and maybe we could give it in more detail to such a person. The studies have clearly indicated, at least whatever studies have been published, that the risk of conversion to MS is lower, is much lower, to the tune of, I think, 5 to 10% in patients who were treated with DMT in attaining CDMS. So that is still a significant number. People who are untreated versus treated. And I would place these facts to the patient. And also, maybe if the patient wants to wait, we could, if the lesions are increasing, this is now we consider this as a prodrome. There's a threshold effect. We understand that there have been papers on that. It's like a threshold, something over the water and under the water. These lesions that you see are basically the tip of the iceberg. There's still in-depth changes in the myelin which is taking place. So if we go by that concept that there is something below the water, so these are nothing but prodromal features on the MRI, and if they are increasing, someday this is going to be, the threshold is going to be crossed surely, and the patient will have an MS. So looking at that, definitely, if it would have been a male patient, I would have started the treatment. In a female, I could have asked the patient. These are studies which show that your risk of conversion to MS is lower if you get treated. And of course, between teriflunomide and I'm not sure if DMF was also tested. I think there's a study on teriflunomide is there definitely. I'm not sure about DMF, but that's what I would lay the cards to the patient. And in a male, I would suggest, and we've done it actually. We've started in a few patients in males on treatment currently.
One thing I would like to add is that in the TERRIS trial, which was the same RIS trial of teriflunomide, the adjusted risk of reduction to the first demyelinating event, it's a small sample size trial, and there are issues with the trial also, was I think close to about 60 or 62% reduction to the first event. Now, if you look at that reduction course of 62% or 65%, and you break up of how many of them would have actually turned around, in placebo, of course, they were higher because we know they would turn around. So I think all of this information should be transcribed, and as all of us have discussed, the associated risks based on the imaging, areas of involvement and others. So you will also get people who do not have migraine but who have actually seizure. They have a first seizure and you did an MRI and you found all this blown out MS lesions. So seizure is not characterized still in the incident clinical features of a clinical attack. But we know seizures are more prevalent in MS. So from that patient, I still feel is more at a risk because his clinical presentation actually may have been because of the lesion. But in migraine, it's such a diverse and heterogeneous situation that you need to be slightly more careful in that.
Thank you. So I think
Just to add on to that, like in some countries, they even don't allow you to discuss. The patient has a right not to know about this whole radiologically isolated syndrome because that scares them to, health. So they have a right not to know about the thing also in certain countries. We are not allowed to actually discuss with them also in RIS.
Thank you. So I would go on to the next case. So this was a 32-year-old female patient. She was a diagnosed case of MS, initially treated with Evonex, and she discontinued due to the relapses. She was shifted to teriflunomide, and she was doing well. And she had, for 6, no relapses, and she was tolerating the drug well. She gets married. She moves from Calcutta to Delhi, and she comes to me, and she said, "I want to plan a family." She had 5 questions. So I will ask all of these together. So first was, can I stop the medicine? If yes, when and how? How will it impact me? How will it impact my child? And will my disease get transmitted to my child? So these are some of the questions that we see when young women who come to us who are planning a family, and this woman was on teriflunomide. So I'll start with Suresh again.
Okay, this is again another patient who's I think proven case of multiple sclerosis.
she's a proven
already
case.
on platform therapy. So initially was on interferon, was not doing well, got repeated relapses on interferon, and then had to be shifted to another first line therapy, which was teriflunomide. So nowadays, sometimes we don't do this because from first line therapy to another first line therapy is sometimes not allowed because that means you're at the same level. So escalation. But having a different mechanism of action, and if the patient has a mild form of MS, you can still shift from one first line therapy to another first line. So that is what was done in this patient. And now the problem is she wants to become pregnant. So teriflunomide is absolutely contraindicated, and it has an X warning box in teriflunomide. So you have only 2 options. Either you stop teriflunomide and wait for about teriflunomide has a very long half-life. Sometimes it can go beyond 12 to 18 months. So planning the pregnancy, this is what is called. So stop your teriflunomide and plan your pregnancy. And this means you stand at a risk of developing further MS attacks. So again, depends on whether she's a mild MS or again a more aggressive MS. But being on a platform therapy, I feel, she would be a mild first line therapy. She will be a milder form of MS. So yes, you can stop. But if you want to get pregnant immediately, then you have only one option. you have to go for a fast elimination of teriflunomide from your system. Cholestyramine is an option, or activated charcoal, one of them you have to use, and immediately wash out teriflunomide from your system. Okay, so yes, Kai, you have to stop the medicine if you want to become pregnant, and this is how you do it. I have already told. How will it impact me? You have to discuss with the patient that you stopping the medicine may bring about a relapse in you, and if there is a relapse, then we have to tackle that separately again with. How will it impact my child? Yeah, if you are not on teriflunomide, I think it will have no impact on the child as such. Only thing problem is if you become pregnant on teriflunomide, then there is a high risk of teratogenicity to happen. So otherwise, if you stopped it early, there is no risk or no impact on the child. Will my disease get transmitted to child? No, because it is possible, but genetic transmissions, familial transmissions, MS is less than 10%. So it's a 10 to 15% genetic disease, and 85% environmental factors play important role in MS. So you should say that if there's no family history of MS, then I don't think so it will get transmitted to child.
Thank you, Dr. Suresh. Rohit, your thoughts on that?
I think the last two are, of course, myths. So we should just debunk them. There's nothing that, unless you have a child with MS and he has an identical twin, and there is a risk the highest. There's a 98.4% chance that you won't transfer. Roughly about 1.8 to 2.2% of transmission, in the sense not really of transmission but child getting. So like, I think the last two are big myths, and we should always debunk them for the lady who wants to have pregnant. The first thing which you should always do when you have a lady who wants to discuss pregnancy is to get her more confident about having one. That is our responsibility as clinicians, to talk to them and explain them that she has the capability and she has the right to have a child, and we can do whatever best we can so that we ensure her safety during pregnancy as well as her to have a child. And unless the child lady is extremely disabled and there are issues that we need to walk on a psychological path to assess that. So teriflunomide, I think, as Dr. Suresh has told, takes almost 4 months to 18 months to clear off, and if you want to plan it, then you give cholestyramine and all that. So my simple principle in my management is that I do not recommend any drug in pregnancy at all till I have a patient with a very strong history of very aggressive disease for which I've already shifted the person to a highly effective treatment. And there I need to plan my modulation carefully. If you're on Tizabri, you can't withdraw fast, you need to withdraw slowly. So you need to get them on board with a more interval drug and then slowly taper it off. If you're on other drugs, it is fine, you don't really get a rebound effect. But as far as possible, you should avoid, because none of the drugs is actually truly recommended other than the exposure periods, small exposure periods of interferon which are permitted. We have some data now coming up of DMF exposure for 4-6 weeks by the time a lady picks up that she's pregnant. Or for that matter, the only drug with level B recommendation remains glatiramer acetate. Now, if you tell a woman that you're going to shift her to a daily injection because you have MS, that's, I think, not really a correct approach. No one wants a daily injection. We also know from a lot of registries now that pregnancy is a relatively safe period for a lady to have pregnant. My only concern would be that I would ensure that she has been stable and disease free for at least a good period of about 1.5 to 2 years. And once I'm ensured that she's doing well, radiology is good, and she's been compliant, and she now deserves to be pregnant because she's already turning 33. You can't just push a lady ki aap wait karo 40 saal. That's not right, medically also. So we need to look at the age, what she's developing, the safety of her having a safe child anyway, risk of downs and others. So we have to bridge all these thoughts, take a clear decision, but as far as possible, no drugs in pregnancy at all. They are all more or less contraindicated other than glatiramer acetate, but we do have data for early exposure before a lady becomes pregnant, that you decide that you want to abort or you want to continue pregnancy. Though that's a completely different trajectory, and we are not discussing that. Yes, we've had situations where women have been on rituximab, and there is no direct exposure immediate, but there is some potential risk of immunosuppression to the fetus, but that's fine. You can go ahead and do that. But direct exposures, no, not recommended.
Dheeraj, any other thoughts?
I think most of the reasoning has been discussed. Clearly, we need to have accelerated elimination, and if we really need to be sure, we also should look at the serum levels of teriflunomide, which we know beyond a cutoff of, I think, 0.03 microgram per ml or something close to that. So we just need to ensure that. But beyond that, I think the most important fact, which Rohit has already elaborated, is the kind of nature of the disease. I would really be interested in knowing how aggressive the disease is. Is it very active, highly active? There will be a fear. And what was the EDSS of the patient? We just heard that she was on interferon, teriflunomide, relapses went off. Was she
I think she was
quite good?
She was not. She was very good, and in fact, we did a rapid
Right.
clearance.
So if she's in a good clinical condition, likely this is not an aggressive MS, because on teriflunomide too, although teriflunomide has a good effect as far as the disease modification is
So
concerned. But
what we did,
still,
we had a rapid clearance of the teriflunomide, and we have allowed her
Right.
to go in for the pregnancy.
yeah. So the safest bet still amongst the currently available medications, apart from Glatimer, which is not available also, and people may not like to take it, versus interferon. I think rituximab offers us the best opportunity in cases of high rituxi or any of the anti-CD20s because of its long duration of its effect. So if somebody wants to plan out, and we've done it in a few patients who were actually shifted from natalizumab. I've shifted them from natalizumab to anti-CD20 drugs. And if they plan a pregnancy, we ask them, okay, last dose of the anti-CD20, plan it 3 or 4 months after that, because an ideal gap, which has been tested in lymphomas for rituximab, is 6 months. 6 to 9 months after the last, which is not feasible. So at least on an average, and there have been studies which show that if people have had conception between 3 to 6 months, they have not had any adverse events. So even if they plan it 3 months post last infusion, the entire period can be tided over, because a lot many times your anti-CD20 count stays low, and the risk in general as a natural history is also low. Postpartum, you can immediately start the drug if there is a high, and there is no risk even for breastfeeding with anti-CD20. So that would be the best bet in case of a high activity disease.
Thank you. So this was a 16-year-old male patient in 2007. He had right optic neuritis, and he was diagnosed to have an RRMS, and this was his MR at that point of time. And his OCBs were positive, his vasculitis profile was negative. He was diagnosed as RRMS. He was started on Evonex. That was the only drug available at that time. He remained well for next 3 years, but after that, he had basically multiple relapses, and he was started on Gilenya in March 2012. His relapses stopped completely. He became totally asymptomatic. There was no disability progression, and he was relapse-free for almost 6 years on Gilenya. And his MR was stable. There was no evidence of ongoing disease activity. So what would you do in this situation? Would you stop the drug? And he plans to get married.
Shall I take that first?
Yeah, please. Go ahead.
Sure. Uh, so again, I think you're showing a very typical case of multiple sclerosis already on Avanex. MRI, I just saw that it's a very typical sites of MS lesions. Few GAD-enhancing lesions were also there, I think, in that. So this patient was shifted to fingolimod. Now, it was due to inadequate therapeutic benefits from Avanex, isn't it? It was escalated to fingolimod. So fingolimod actually, in some countries, it is considered as a second-line therapy, while in certain countries, it is still considered as a first-line therapy. Like for US, they consider fingolimod as a first-line therapy, while in Europe, it's more considered as a second-line therapy. So anyway, here it was used as an escalation therapy because of inadequate effect Avanex. After that 6 years, the patient has been not on any relapse or any, and patient is stable. Now the question is whether you will stop this patient. I wouldn't stop at all, because any when you stop these kind of therapies, the relapse, rebound relapse can happen at any time, and sometimes they are much worse than the initial relapses what the patient had. So, any patient who is on multiple sclerosis therapy, as per current evidence, I don't feel that they can be stopped on any medication as now. There has been debates on this, whether, if the patient is not active for many years and the patient is after 50, age of 50, whether we can stop these medicines. So the debate has been always been going on. There have been papers on this, published literature on this, but I think no. In this situation, I would be, uh, I wouldn't.
Rohit,
थोड़ा मुश्किल सवाल है.
तभी तो
Not
पूछ रहा हूँ.
yeah. So this difficulty is not only for a clinician. This dilemma is for a patient as well. And obviously, when we see a patient who's 6 years into the illness with a drug and taking a drug like fingolimod, which may cumulatively also increase the risk of PML, lymphopenia, and other issues, that is there in the back of the mind. But if you go back into the story and see that he had failed a drug and he had to move to another drug, which is also well known in MS. Honestly speaking, looking at the age and looking at his stability of the disease on a drug which is convenient to take, can be well monitored both radiologically and in drugs, I think I will discuss this with the patient, give him the information that has been available, and the uncertainty, but at the same time a general perception and consensus of most of the clinicians that it may be more prudent to continue medication. I mean, we should not create a taboo other than him being on an immunomodulator with a suppressant property. That concerns us, but not with the fact that he's taking a drug because of a disease that he needs to take for a long time. There are many diseases which require long term treatment. So from that angle, I think it may be good to continue. He's planning a pregnancy. He's going to be a father. We don't want him to have any instability of his disease. So I think I would, as Dr. Suresh said, tend
So,
to
okay.
continue treatment.
So I think we did that, and he gets married on fingolimod, but post marriage he develops optic neuritis on fingolimod, and he has multiple episodes, and he loses his vision in the right eye. He switched on to rituximab. He receives 2 cycles of rituximab, but he continues to be worsen. So my question to Dheeraj now. So what should we do now? Should we switch over to Ocrevus, ofutamab, tisabri, alemtuzumab, cladribine, or BMT?
Well, yeah. So it's in what way does he deteriorate? Is he going down in
yeah,
attacks?
yeah. He lost vision in one eye,
And he didn't recover from that vision loss. Did the vision recover after?
No, he has lost vision in one eye. He is having bladder symptoms. He is having difficulty in walking. So all this has happened, and he was on fingolimod. He received 2 cycles of rituximab, but he went down.
Okay.
So what would you do now?
Well, that's a kind of a very tough situation. And see, this is what the threshold is. So maybe he reached his threshold where his the neuronal reserves failed, and he started deteriorating. And he's going into currently, is this progression or worsening stepwise, or is it sustained disability as we call it?
I think it's a stepwise. He has had
Stepwise,
stepwise regret.
meaning thereby that the attacks are leading to a disability, and he stabilizes after that disability, and that disability persists. Well, one of the options when CD20s fail is to take another mechanism. Ocrevus is out, because I will not expect. Ocrevus has maybe a marginal benefit which has been documented by certain studies. But I would shift off to another mechanism. Either I would go to natalizumab, which in effect has been one of the choices which is resorted to in cases of failure by anti-CD20s. So that is what I would discuss with him. Or alemtuzumab may be a choice, because this is one of the indications of alemtuzumab where all other drugs are failing and he continues to have an attack. Alemtuzumab, and he's right now he's married, he's had a baby.
Yeah, he's married at about 32.
Yeah, so fine. So alemtuzumab would, of course, entail lifelong monitoring of certain things, and also has he's not had a child as of now.
No, no.
So those things would have to be considered whenever we are using these drugs. So in that condition, that it could be offered to him. Alemtuzumab would be one of the agents, not the very highly toxic agents. BMT versus alemtuzumab, I would cladribine would not be a great choice. It affects your DNA, and that's going to have long-term side effects. So between Tysabri, alemtuzumab, and BMT, we have a discussion, and maybe give him a try of Tysabri first. Although we don't have enough time, we can't wait further for his deterioration. So between the two, alemtuzumab or Tysabri would be my choice.
Rohit?
I need to know one thing from you about this patient. Did he actually stop his fingolimod?
No, no, he didn't stop the
Okay.
fingolimod. He can't. We actually, he was seen by some. He's been my follow for almost now 17
Okay,
years.
okay.
So he was very keen to stop the fingolimod. He had taken a few opinions who had told him to stop fingolimod, but I told him we are not going to stop it. So I
Yeah.
was very, very clear. So we didn't stop the fingolimod at
Because
any point.
one thing which young people and residents should know is about the two drugs, especially Tysabri and fingolimod, have a very strong rebound disease activity. And it can be so bad that you may need to give steroids, plasmapheresis, and everything to bring them back. So that's one thing. So if it's not stopped, then it is a natural disease escalation which is having, which is, of course, generally happens if there is a rebound activity. But nevertheless, expecting that he was telling the truth and he was not stopping his fingolimod. So the bigger problem is when you want to switch these patients to another agent. Now, our reliability on rituximab is based on not only its efficacy, but I think it is more to do with its cost and easy availability and its ability to transcend patients' choices because you're going to give them once in 6 to 8 months. If you really ask me as a clinician and with my experience of managing patients, and I don't know, Dheeraj may also resound, and so with Dr. Suresh, that the one drug which has always shown us the efficacy during the high disease activity has been natalizumab. I think that's one discovery in MS which changed practice for patients with highly active disease. And and for people where it has been started on a real exact great time window or that real sweet spot, they have done very well when they were relapsing MS. Our two problems are that is the JCV and the cost. So in this patient, if he's already been on fingolimod, the choice of natalizumab will be strongly directed towards his JCV status. I agree with Dheeraj that we before offering him, because honestly, I'm not too sold out on drugs like alentuzumab. If you look at their individual efficacy and look at their comparative observational data set analysis, it is not far different from CD20 drugs or for that matter, even with Tysabri. They look quite similar. It is only that we move from one to a different agent where we have failed. And why alentuzumab is among those lists of drugs that you have failed at least two or more? And why did European Medical Council relook at alentuzumab? Is because of its inherent safety issues. We have to understand that it is not a greatly safe drug. There are potential concerns with young people, even if it is rare, but you can have that adverse effect. So, as Dheeraj mentioned, that maybe he's a candidate for natalizumab. Yes, if they can afford and they want to go with expected adverse effects, if he's JCV positive, you cannot give him Tysabri because he's already been on fingolimod. So that characterizes him at a very high risk for having PML. So I think that's a bad choice. The best choice will be to consider another drug. As Dheeraj mentioned, consider alemtuzumab, but I will strongly also consider bone marrow transplant, AHSCT, for such a young man with such a relapsing disease, disabling disease. Yes, the child is an issue, so you can always do a sperm banking, and that's not something we don't do for young people. We've done ovum banking, we've done sperm banking for people who had to go to AHSCT because the disease was so bad that the priority at that moment was to take care of the patient rather than consider about his fertility issues. But I think that option definitely needs to be on card as well. But we should do a JCB. We could consider Tizabri because it's a great drug. We could consider alentuzumab, but we should also strongly consider
bone marrow.
AHSCT.
Thank you. So I'll go to the next, I think, with the passage of time. So there's a 38-year-old male, history of progressive walking difficulty for last 1 year, bladder symptoms. He visits a spine surgeon, undergoes an MRI cervical spine. The cervical cord shows demyelination. The MR brain is consistent with active demyelinating disease. The CSF is positive for polygonal bands. So a diagnosis of possible primary progressive MS is made. So what should be the way forward, Dr. Dheeraj? Would you go for Ocrevus or rituximab?
So, although there are it's an approved indication
And
for
affordability
Ocrevus.
is not a question. Affordability is not an
Fine.
issue.
So no, I was just coming to the approval. So the approval for PPMS is there for Ocrevus. Agreed. But for a certain reason, I've stopped using rituximab for PPMS because initially when the approvals came and Ocrevus was not available, we tried using it in a couple of patients, but I've had very dismal effects or dismal experience. Uh, the most probable or the most likely patient who would respond very well is something who has some degree of activity in the progressive phase, either in terms of progression or evolving lesions, or you may have on some successive MRIs there are lesions which are increasing. So Ocrevus could be a good choice, or of course you said like affordability is not an issue. So we would use Ocrevus. I would definitely offer Ocrevus since that is labeled. That's got a label for PPMS. Rituximab hasn't, and the experience also with I think we've not had good experience, and that's what people have shared. We've heard from other people also, and there's been no studies on this in PPMS with rituximab.
Rohit?
See, reverse is a approved drug because a trial was done for it. If you go by the mechanism of action, it's almost the same as rituximab. So honestly, if you give me money, I will definitely like to do this trial, but no one is going to fund that. It's too expensive to do it, other than doing a small sample size study for a proof of concept. But here you are proving efficacy. Even if not efficacy, you're proving at least non-inferiority because rituximab is not an approved agent. Said so, and I may slightly differ with Dheeraj here because that is his personal experience. Because we know in primary progressive MS, you're not looking at extraordinary results. You have to understand this disease tends to progress. And even in the Ocrevus trial, Olympus trial, we knew that there was a difference in the rate of progression and stability in one group versus the other. So I still offer people rituximab. There are lots of patients whom we are treating with rituximab who have primary progressive MS. We have relative successes, we've had relative failures, and that would happen in Ocrevus also.
Suresh?
Yeah, absolutely, I
Ajay.
would agree here. See, what I just look at in cases of secondary progressive multiple sclerosis and primary progressive multiple sclerosis is there any little evidence of activity somewhere, clinically or in the MRI?
So this patient had activity, he had active lesion, active disease.
So once there is an activity, you should treat them with a drug. The inactive SPMS and probably burned out primary progressive MS, no DMT is going to help them. So it is only going to help the active SPMS and the active primary progressive MS. So you have two drugs. One is a drug on which the oratory trial was done, and it is proven in a phase 3 trial that it has helped, that is Ocrevus. The only thing is the cost, the huge cost which comes with it. The question is that if a patient is not affording Ocrevus in a PPMS, active PPMS, will you give the choice of rituximab to that patient? Yes, I think I will give it the choice of rituximab, because what we have to know is that it is not only the gait which actually improves in patients with disease modifying therapy. Lot of other things like spasticity, pain, bladder, these symptoms also have a small little effect on by disease modifying therapies. We only look at the gait and we say that there's no improvement, the patient is wheelchair bound even now. But what about the non-motor symptoms of multiple sclerosis? It has been shown that non-motor symptoms also have some effect with DMT. So obviously, if the patient is not affording Ocrevus, I will give choice of rituximab.
So I think Dheeraj wanted to add something.
Just adding on, the good old drug as a thiopurine, that seems to, in fact, one of the guidelines, the last guidelines published in the by the American Academy of Neurology, they accumulated the evidence and found azoran to be effective in all forms, especially the progressive forms, and we use it quite often. And what has been observed is that the disability almost kind of becomes static with azoran.
So we went ahead with all this was about 3 years ago. We went ahead and gave him Ocrevus. He's still on Ocrevus, and he's done wonderfully well actually. And I think so. I'll just go into the. So this is a 26-year-old female, patient of RRMS, and she has been on DMF for last 2 years. She's relapse free. There is no worsening of EDSS, and she undergoes her yearly MRI. And the two small enhancing lesion, periventricular and in the supratentorial compartment. So now the question is, should I do a switch? Should I escalate? So I start with Dheeraj this time.
Well, just lesions alone, we all, I hope we would all agree on that. Lesions alone without progression or no attack,
relapses.
no need to change. We see this quite often, and that is the reason we've stopped doing very frequent MRIs also. You are getting an MRI done either every 6 months or 1 year. So now even our gaps of MRI and also the new recommendations for the imaging are telling us even not to do a contrast every time. So we could actually forego that. If the patient has not a single symptom, I won't change. We stick to the same. And that also goes by the Canadian Consortium guidelines. If you see those concern. Those lights, red, green, and orange. So this is really a very, very low level of concern. The level of concern with just lesions without any new symptoms is going to be very low. We could take some opinion from the audience too if they have any.
Yeah, if anybody has a different opinion, please, you are free to go ask. I don't think Rohit.
So it's a bit of a tricky issue, and it is again a very hot debate topic: imaging and decision for switching. Because why we do imaging is to look for stability, and if you're looking for stability, then that tells us that there is an underlying disease activity. But the biggest problem is when you find non-enhancing lesions, and that's when you don't know when they actually developed. But because enhancement is supposed to be some kind of a more theoretically, I really don't know biologically, but theoretically more of a recent activity that will light up over the past few weeks or few days, which is still lighting up on as a contrast. The Canadian recommendations or the Cantor recommendations previously would categorize 2 or more lesions as slightly worrisome, means medium to high worry, not high worry, it's more than 3. But if you look at the Magnum's criteria or the Magnum's MR criteria, they say that if you stay below the three new lesions, of course the contrast will have a more concern, but 3 new T2 flare lesions without disability, you may categorize them still as on the lower threshold of decision making. But if you have a contrast enhancing lesion, you will tend to at least explain, and you need to allay the anxiety of the patient, because as a clinician, I'm also anxious in back of my mind, because you are concerned the patient may not relapse in the near future, and you said to the patient nothing will happen, but he actually or she actually relapsed. So I think enhancing lesions are still at the threshold of decision making, and it all depends how we perceive the patient's underlying disability, underlying clinical status, that EDSS at the time that we were actually gauging this MRI. And if there has been a person with some more disability than usual, with more new enhancing lesions, you would slightly be concerned that am I giving the right agent? But someone, as Dheeraj mentioned, absolutely stable, you need to discuss and give an equipoise of an uncertainty principle here. But most of the data would suggest that you need to follow these patients more closely and intercept if there is a new disease activity. A contrast enhancing lesion, you need to definitely follow more closely.
Suresh, any
Yeah,
take?
absolutely, I agree with that. If there's a single contrast enhancing lesion, that patient has to be very carefully monitored. Some centers even escalate based on contrast enhancing lesion. But T2 lesions, non contrast enhancing lesions, you can still wait and see. But as Dr. Rohita said, closely monitor, maybe a scan after 6 months to see if the number of lesions are increasing, and then only go for escalation. So in this particular patient, I won't escalate at this point of time.
Thank you. So now the last case, and I think this is a common scenario which you were discussing previously. We had a 40-year-old female. She's a known case of RRMS. She is on DMF, and since 1 year, she has noticed increasingly walking difficulty. And examination, she had a spastic paraparesis. EDS has worsened to almost 5. The MR brain when the spine with contrast shows no guard enhancing lesion. There is no increased number of lesions, no enlarging T2 lesions. So now the question in this patient is possibly we're dealing with a patient of secondary progressive MS. First question, should we continue DMF or we switch over to betaseron or a CD20 therapy, tisabri, alemtuzumab, siponamide or BMT? So again, I would start, now this time start with Rohit since what he has.
So, good question, and I think a good scenario with a difficult decision making in the clinic. So, one thing is that we would categorize some of these patients with a sustained disability progression as SPMS. You would probably start placing them into that progressive deterioration phase and say this is SPMS. Now we can use the term progression independent of relapse activity or the PIRA, which also has its own variations with or without disease activity, clinical or radiological. So, as you said, this is most likely PIRA or SPMS with no evident radiological disease activity. Now, the biggest problem of treating SPMS, or for that matter, people with an originally relapsing disease or a relapse onset, is we do not have much data to support the choice of the drugs. If you have disease activity, then we know some of the RRMS drugs which are highly effective agents, including ofatumumab, including your Ocrevus and others, also have been approved for SPMS with disease activity. But here we are dealing with a theoretical patient and following a very sustained book tick picture, no MRI activity, so nothing can be done. I think that's probably not a good concept. If it is just about a year and patient has deteriorated, we should still consider to give the patient a good option of moving on to a more highly effective treatment. I think honestly, Tysabri, because it has already been tried previously in this group of patients, did not show a significant benefit. And looking at its cost, JCB issues, monthly infusions, I although may think my Tysabri dunga and patient may get better because it's a good drug. I think the analogy has to be taken from a progressive MS data and also from a relapsing remitting MS data which are deteriorating. So we buy those analogies and fix them into this patient. So I think my choices in this patient may be to do more with, if you want to go by a very approved agent, you may say siponimod, or let's say if you want to buy the analogy of primary progressive MS and patient is affordable, I may say you want to try Ocrevus because it has been used in primary progressive MS. But honestly, what I do in practice is I don't have cladribine because oral is not available in India at all. And injectable cladribine has limited case summaries and reports. It is not even recommended. I generally start with rituximab for these patients, follow them up very closely every 3 months, put their examination in detail to find out, and of course, take a subjective opinion how the patient is feeling in the ambulation. Not to say that, and not for the residents to know that you would also treat them for symptomatic improvement with lyophene, with rehab, with maybe an addition of delphampiridine for some required patients. So you will do all of that still. I generally add high dose biotin for most of these patients because it has worked it has small data to support in SPMS, or I would offer these patients AHSCT because there is a lack of certainty for using other drugs. So these are my two choices are generally rituximab or AHSCT. My third is to add other non-descript agents like biotin and supplement treatments with symptomatic treatment. That's what I do in practice.
So what doses of biotin you are using?
I'm using up to 10 milligram because it's almost 10,000 units.
Dheeraj?
Well, almost a similar approach I would have. One is a thorough examination to see what is leading on to the deterioration. I would look into the symptomatic treatment, add dalfampridine if the walking difficulty is related to not actual loss of power, but maybe spasticity and increasing loss of, bad, maybe patient has not had good rehabilitation. So adding on those two treatments, the choice of treatment is very difficult. We usually don't switch to any other thing like anti-CD20. Like I said, I've not had very great experience with rituximab in progressive patients. Short of adding this and biotin, which the trials for biotin were actually 200 to 300 milligrams per day. And we have only a 10 milligram tablet available. So I was actually very excited when the first trial came, but the large phase 3 clinical trial was negative. So then we stopped using high doses. Otherwise, I was using close to 100 milligrams, asking them to take 3 tablets 3 times a day, and or get it from US where you have 100 milligram tablets available. So that coming out negative, we stopped using it, but we still add on a small dose of biotin, which might help. Out of the treatments, I would, it's not, we don't juggle around with treatment or take the best, ask them to take a slip of the thing. Saponimod is not available here, it's expensive, so we just tell them that that is the approved treatment for SPMS. Short of that, drop back, and if I actually document progression, so I wait for at least documentation of the progression, which is looking at either the EDSS. Along with that, the most sensitive way to look at deteriorating status is a 25-foot walk test, which you can easily do. And I almost have a 6 monthly 25-foot. So if there's a 10 to 20% drop, we need to look at a 20% drop.
Has already deteriorated.
Right. So if that's deteriorated, looking at the walk and a sustained disability, that you're getting disability happening every 2 to 3 months, then of course either of these drugs between saponimod, I would be wary about the other drugs, or just put them on azoran. So like the good old azoran had some evidence accrued in all forms of MS, and in fact previous data from the guidelines also say if you in resource limited, that's one of the best drugs to be used.
Suresh?
One thing I want to add here, and I will strongly differ from Dheeraj on this, is that you can't lay down back and say, I will wait for another 6 months. You have a lady with optic neuritis now, EDSS of 5. This is clear evidence that she has disability, remarkably progressed. And I can tell you, most of the people miss that spot in SPMS. We don't have editorials or articles and trials written on that. But I can tell you we've had successes. And obviously, because these successes are known to individuals, they cannot be recommended. But there are those patients who we initially start to see deteriorating. And that's where the beauty of good clinical follow-up comes, that you don't wait for them to deteriorate further. In SPMS, that spot has to be found. And that is generally missed in most of the patients. By the time they end up coming to you or they come to you, people have not examined, they've not put notes, and people have not seen their ambulation deteriorating. They will keep on juggling with their own internal defiance that, no, it may have been because of that, it may have been because of that, but they've actually deteriorated. And that's the time you need to hit them hard, because you're not now dealing with an inflammatory disease, you're probably dealing with a downstream effect. And maybe your tyrosine kinase inhibitors or BTK may do something, but let me tell you, you need to find and hit them hard at that moment also. Give them an opportunity, because you still have other regions of the body to spare, because patient is still effective in its work. You can't let cognition go down, you can't let vision go down, you can't let upper limbs go down. You just can't look at only ambulation. You have to look at the patient in totality. So I think you need to find that spot.
I would agree with that. I think we need to be a little more
So
aggressive.
agreed, we need to hit hard. I didn't mean that we wait for 6 months for things to go down. I am looking at the preceding deficits. If we are very sure that this deficit has been continuously going down, now the problem here is where do we hit hard? You're saying hit hard, but hit hard what? You don't have inflammation to hit hard. So what do we use? It's like hitting. That's what I consider hitting in the dark. There's no inflammation. It's an axonal degeneration. And we still don't have remyelinating agents come up. None of them have proven to be right. So hitting hard is right, but most efforts with hitting hard have not proven to be really great. And that's the reason I do agree that we could give it a try, but I don't know how many of us had successes unless there is some element of activity in the SPMS, some degree of, say, increasing number of lesions. You have contrast enhancing lesions. Definitely hit hard using anti CD20. I won't mind. But if you've got complete bland MRIs and no evidence of activity, you're just, at that time it's very difficult to really consider even these strong agents. At least some bit of experience that I've had, we don't really reach anywhere using these
So,
strong agents
The
too.
same
coming back to another
analogy, the
question, do you
same
think,
analogy, the
yeah,
same analogy is in primary
yeah,
progressive.
hmm,
There is no evidence.
noted.
The MRIs are bland for decades, but the trial was done now. They had to do something.
So
We
I
have
would,
B cells active more in
no, no,
Use
I
PPMS.
would
them.
just
Use
come
them.
one more. So I would just come from that is about PIRA, like progression in spite of.
Relapse activity,
So
independent of
in
relapse.
PIRA again, we are trying to basically trying to treat PIRA also. So that's, I think,
If that is
the
PIRA.
truth lies somewhere in between. I think there is
PIRA is a transition between
transition between.
RR and SP.
So I think there is no harm in over treating.
I think we will have some data eventually analyzed from our national MS registry. We have a large number of patients on rituximab, Dheeraj, and all. We are all a part of it, and we will have breakdown of patients with well collected data to say what happened to these SPMS which were treated differentially. So hopefully in the next 6 months we should be out with that analysis as well.
Suresh, the final word before
Yeah,
we end.
yeah, I think absolutely. Now, I think radiology needs to help us more in the future. Like these chronic active lesions, which are hemosiderin laden, these are not currently picked up by our or routine sequences. But if we are able to do these, the chronic active lesions, etc., can be picked up, or the follicles which are present in the meninges, which is the cause of progressive MS. If there are ways by which we can see them by imaging, then this question answer becomes much more
Much more
simple.
relevant.
So
Yeah.
we have to wait for
So I
radiology
think
to
we have to
give
wait
us
for a
that.
7 Tesla MR. We have to wait for a MR to show us the PIRA.
There are those putaminal rims which have been described, but again, they are not very sensitive. There have been signs on, there have been papers on putaminal rim, etc.
Now, why these terminologies are changed is to give us a better adaptive understanding of how the patient disease looks like. There used to be, you must have seen, and we have seen patients who had one relapse and then were silent, and then they suddenly only went deteriorating. Those patients used to be called single attack progressive MS way
MS.
back in JNNP articles. But then that terminology and that classification disappeared. Then someone thought how to classify progressive MS. Should we classify clinically or should we even classify radiologically? So people came up with a suggested recommendation for classification. And the same suggested recommendation is coming for PIRA now based on imaging. So I think we just obviously want to increase our understanding and make right choices for patients and give them some silver lining that it may be hope. That's what it is.
Thank you, all three of you. Thank you. Thank you for a very, very lucid and interaction and very informative. Thank you. I hope everybody enjoyed the interaction. Thank you. Thank you. You have a question, please.
So a patient of typical optic neuritis having positive OCBs. Now, when do we decide whether to, go for the therapy or wait? So there's a new test, kappa FLC, free light chain, which has some additive prognostic value apart from OCBs. So OCBs are only subjective, that visual bands, and they don't carry any prognostic values, although they substitute for DIT, but these FLCs, if the index is more than 100, I would definitely treat. So the patient with typical first CIS and having a positive OCB, I would go for a kappa FLC. The only challenge is we don't have that freely available. I tried to find out about it maybe 2-3 months back. So I want your
So
opinion
yeah,
if it's
it's a very pertinent comment. I was about to mention the kappa free light chain. There was a recent paper actually comparing OCB. So what we do with the kappa free light chain? It's an alternate. It's an alternative to OCB, almost having equal sensitivity and specificity in detecting MS. You're quite right, and it's a lower cost. In fact, that paper it's either in JNNP or I don't recollect which. Around 2-3 months back, it came in. So it referred to the low cost effectiveness of having a substitute biomarker. But you're right, if we could get that, it would go in favor of something which is, I don't know if it is specific or MS directly, but it would give us an indication that there is something like demyelination happening. Again, this is not a diagnostic biomarker. It is an alternate to OCB, which is intrathecal IgG synthesis, and kappa-free light chain is another offshoot of the immunoglobulin. Basically, it's just nothing but
yeah,
an offshoot of the immunoglobulin, the free
just
light chain.
common markers for chronic intrathecal inflammation.
Exactly, inflammation. So it's non-specific again.
Yeah,
So if
non-specific.
I would not be sure, like it is not, even OCB is not being labeled as an MS biomarker. It is labeled as an activity biomarker.
Yes, sir. But there is a point that it does carry some
Agreed, it's an
prognostic
additional
value.
thing, yeah.
So if the index is more than 100, we surely know that the patient in the next 12
Agreed,
months will
agreed.
convert into a
So that
MS.
could be taken as a additional biomarker, and availability is there actually. If you call up the labs, they are doing it in serum, but not CSF. Serum kappa light chain is available here.
Okay, I was not aware because I tried for one of my
Because
patients.
the nephrologists get it done.
So, but we don't have a standardization for that
standardization.
in the CSF. That is the
Yes,
challenge.
yes, exactly. Okay, thank you. Nice comment.